Welcome to episode number 7 of the Basics of Medicine. Major flaws in medical practice. Last time I showed you the major flaws I observe in medical research and development, and today I discuss the major flaws that I observe in education and especially in medical practice. So, this is the last episode where I discuss the status quo, the current state of medicine. Remember, I'm doing this to try and find the explanation of why medicine is ineffective today. So I'm Davide Patti. I am a scientist and I work as an independent researcher. First off, on the left, you see the topics I will cover today. So let's start. Compromised education. So we see in this illustration from previous lessons that research and development is controlled by the medical industry. And so we understood how scientific knowledge is influenced by this, and also that the subsequent steps of the process, which are education and practice, will be compromised. Today's practice is based on drugs, devices, and also procedures. These are practically all brought forward by the medical industry. These are the tools available to physicians today. And so the focus of any education is going to be to prepare the physicians to use these tools. So it's interesting to note that the tools of medicine have changed dramatically in the last, or in the 20th century, and so has the education. Today we have many more tools and also much more science produced by the industry, but the reasons are historical. We accept the status quo. So the illustration here represents the total knowledge relevant to medicine. What is it comprised of? It's first of all basic sciences, so biology, chemistry, physics, mathematics, and there are overlaps. So let's say biochemistry with focus on the human body, of course. Then there is a lot of additional science found in research literature. We see in data for from 2010 that counted more than 500,000, 500,000 research papers published in English language. So of course it's impossible for any practitioner to learn all of this. On the other hand, we accept that medical devices, drugs, and procedures are the tools available to medicine today. So the knowledge which is taught to physicians is going to be a selection of the total knowledge, and it will be primarily knowledge that is linked to or developed around the tools that are available to practitioners. It would be basic sciences, of course, but it's not going to be the total, and it's going to be predominantly the science around the tools. Now, what happens once in practice with education? Regarding education, with new tools are made available from time to time from the industry. Practitioners will be informed either directly from a representative through a visit or a industry organized congress, or more indirectly through continuous education programs. So this is how the drug and the science linked to the drug is going to reach the medical practitioner that will then forward the drug to the patient. Now, physicians have little motivation to read published research. Why is this so? What are reasons? First of all, we saw how the medicine is an allopathic medicine, so you're used to you're taught to learn, you're taught to use drugs to address the disease in its expression. This means that most research will be considered impractical and also relevant, therefore, because it is not linked to a drug directly necessarily. So, a second very important reason is the amount of knowledge. So it's impossible for a practitioner, regardless of his or her specialty, to follow the research relevant to him. So I can give you a simple example that will make this very clear. So a neurologist takes care of more than 100 diseases. If he wanted to follow the research on just multiple sclerosis, so this is one of the 100 diseases, it will require him to read up on research 13 hours a day, 7 days a week. So this is based on the data in bracket data, the assumption in the bracket. So there were 7,500 papers published so far in 2017, and we assume that it takes him 20 minutes to read one paper. Then there is another point could be that the large amount of knowledge learned during the initial education. So physicians are highly trained, highly educated. So this can give the impression or the confidence that it is not necessary to continue learning. Then, of course, there's the high workload documented in the medical practice. We saw this previously in I think the second last or the previous episode. I don't remember. And then, last but certainly not least, there are clear rules on how to practice. So there is textbook the practice needs to happen according to textbooks. So there are rules on how to diagnose. There are rules on how to treat a diagnosis and practicing outside the textbooks carries a risk. So reading up on research does not is usually not information that is in the textbooks, because as we saw, most of the information is not in by definition in the textbooks that are used by to train practitioners or to regulate practice. So as a consequence of this is very important, and also the consequence of the fact that information today is universally accessible, but also that more and more people have university degrees. It is not difficult for a patient today to have a better scientific understanding of a disease compared to his or her practitioner. So this is very realistic given considering these circumstances. Now moving on to the next topic, which is reactive medicine. So I said today's medicine is centered around clearly diagnosed diseases. As long as there is no diagnosis, there is also no treatment. So even the symptoms or biomarkers which are out of reference ranges do not matter if they are not linked to a diagnosis. This means that a diagnosis usually happens, or let's say a diagnosis can happen when a pathogenic process has created enough damage to become relevant. So I can give you an example in autoimmune disease, which is when the immune system attacks the own body tissue. So even if medicine discovers an antibody, it doesn't lead to a diagnosis until there is damage to the tissue itself. So you understand that this, to me, is a suboptimal reactive and disease-centered approach. So our next issue I see is ignoring natural variants. Diagnosis relies on lab references. So if you wonder where these ranges come from, These are usually derived statistically. I did my research, usually considering two standard deviation of a sample. So let's look at an example. We want to measure, we want to set the reference range for testosterone. We take 100 healthy males, we measure their values, and we discard the values outside the two standard deviation. In this case, it will be 2 and 2, the two highest and two lowest. And this leads to a range from 350 to 1200 grams per deciliter. So this is the actual range for the testosterone for young males in the USA. So this is a huge range because the value actually is different from person to person depending on the lifestyle as well as other factors. So I see this as a problem. I can show you why. So let's say the person that previously had in his healthy state had a value of 950. He feels off and his lab results show a value of 400, and the physician will interpret this as a normal value for testosterone, even though this is a low value for this particular person. This, of course, is dangerous because the low testosterone is a sign that something is going on in his body. Now, let us look at another example using shoe sizes. So a normal range, I estimated for adults is going to be 36 to 43 European size. So if I wear a shoe size 40, this will hurt me. This will hurt. Even though this shoe is in the normal range. So, of course, this seems simplistic, but the fact is that there is no reason to disregard physiological variance. We do not disregard anatomical variance, so modern medicine disregards physiological variance. Almost, from my opinion, this is dangerous. Or suboptimal, let's say, dangerous. The next issue I see is the nature of modern medicine, which is the allopathic approach. We know where this comes from. I discussed this extensively. So what is allopathy? Allopathy, I wrote it down here. It's a practice that combats disease using tools, mostly drugs, to produce effects which are different to the effects produced by the disease. So it's approaching the symptoms, if you will. Now, I consider this approach an issue, as it would make more sense to address the disease more upstream for the patient, more sense for the patient. So here are other issues I see in medical practice. Some of these are self-explanatory. Some of these I discussed previously. You can find details on all of these in literature. First of all, industry incentives. So this means medical practice adds, or medical industry adds incentives for practitioners to, for example, sell a drug. So they can involve a practitioner in revenue sharing. Then there are Congress invitations, of course, sponsored subject matter experts, which are created by the industry. Then there are also incentives for recruiting, usually monetary. So the practitioner gets money for every recruited patient. I see these as potential issues. Then we have burnt out practitioners. This is certainly an issue for an effective practice. Then care affordability is a topic This varies greatly between countries, different countries. Different countries have different service and drug prices and also different coverages. Then I see a lack of the English knowledge as a potential danger for an effective practice. This because I say that my medicine is also a scientific science, so English is a requisite for me. Then lack of standardization. So the units of the lab ranges or the lab results vary between countries, and not only the units but also the ranges themselves. So there is a lack of standardization there. Other issues I see are when a practitioner does not accept the objective failure of modern medicine when it comes to chronic diseases. Other issues are having multiple doctors that need to coordinate their work, polypharmacy, which is when a patient needs to takes an array of drugs which are not that can potentially interfere with each other. These are not that are not studied in use together. So there's no data on the safety of combining these drugs. Then I see short session times, long waiting times as a potential issue, or let's say suboptimal sign of suboptimal practice. Then I see Medi-Chinese. This is a term that means that medical practice uses terms that can sound unnecessarily complex and are sometimes outdated and sometimes wrong today. I also see a lack of remote consultation as a sign. These are all potential contributors to ineffective practice. Now, same as with medical research and development, I observe misconceptions in the public regarding the medical practice. And again, there are no references here. These are facts from that I presented previously or presented in previous episodes or in this episode. So, first of all, it's a misconception that becoming chronically ill is part of the aging process. We see that chronic disease incidence increases with age, but this is not normal because this is something recent. Chronic disease is something recent, so it was different in the past. So this is not a natural consequence of aging, of the aging process. Then it's a misconception that physicians are up to date on research. I showed you why and how this happens. Simply, it's not even possible given the high workload. Then it's a misconception that modern medicine is effective because, yes, it is very effective for fixing trauma disease, but it is very ineffective for chronic disease. And because chronic disease is much more relevant today, I said that modern medicine is ineffective. Then it's a misconception that modern medicine is not a business. This is, of course, makes no sense, but some people still think, I don't know, that medicine is carried out by university institutes, and that's it, without involvement of companies. I don't know. I showed this in the previous episodes. Healthcare is primarily a business. Then it's a misconception that physicians play a central role in the creation of medicine. This is absolutely false. So the medical industry creates the tools for medicine, it determines the practice of medicine. Physicians are at the intersection between the medical industry and the patients. They bring patients into clinical trials and they bring drugs to the patient. Uh, I have added an illustration at the bottom here which shows this. Also, it shows the size of the circles, which are representative of the capital available to each group. So medical industry has much more money than the physicians, and the patients, of course, they pay physicians and the medical industry. So the size is the sum of the medical industry and the physician. Uh, so to give you an example regarding this, in Switzerland there are around 35,000 physicians with an average income of 200,000 Swiss francs. This sums up to 7 billion, and 7 billion is the profit of just one Swiss pharmaceutical company, a company I used to work for. Now, all these issues I have pointed out so far can be recognized by a practitioner, and a practitioner might want to take action and change the status quo. Now, on this slide, I point out a few issues why this is going to be difficult to do. First of all, I said the practice is highly regulated, so physicians need to practice according to the textbooks. If they do not practice according to textbooks, they can get reported. They risk sanctions. They risk to get sued, but they can also potentially lose their license. So in the worst case scenario. Then second, physicians are highly educated. They are highly invested in their education, so they have money and time invested in education. So of course, this will make them more risk adverse, this high investment. They don't want to lose it. And third, changing practice requires new learning and also requires paradigm changes. So it requires work. And last but not least, there's peer pressure from colleagues. And of course, there's fear of becoming a black sheep, stepping outside of the herd. Then we understand that changing the practice, given all of these conditions, this requires a huge activation energy. So people who change their practice are usually they usually do so because of their own illness or the illness of a close person. So I have added here that insanity is doing the same thing over and over again and expecting different results. This is a quote from Albert Einstein. So the people that step out of the line and start to change are the only people that are actually not insane per definition, per Einstein's definition. Yes, I have concluded my analysis on what are the potential issues that play a role in today's medicine being so ineffective. I now confidently say that the main issue is that we have put the research for our health in the hands of private and, by definition, profit-driven companies. These are by far the most powerful players in the medical landscape. So I see science and also practitioners as direct victims, or let's say practitioners are victims. Science is a tool, as we saw, and a powerful tool, but it is a double-edged sword. So practitioners are victims of the situation. but I also see that patients are is the group that suffers the indirectly, but they suffer the most. So thank you for your attention. I hope to see you in the second half of this series on the basics of medicine.